The following podcast is part of a certified educational activity titled Understanding TYK2's Role in Psoriasis Pathogenesis and Taking a Practical Approach to Realizing Its Potential in the Clinic. Access the entire activity and complete the post-test at peerview.com/XMX860. Downloadable slides and practice aids are also available.
So thank you so much for joining Dr. Lebwal and myself for a talk on understanding TYK2's role in psoriasis pathogenesis, and also really taking a look at practical approach about thinking about therapeutic potentials. So today we have a few different objectives. Number one is to understand the mechanistic rationale for inhibiting TYK2 in psoriasis. And then also we're going to take a look at classification of disease severity, but thinking about that in the context of how our new oral therapies may help to treat patients of different disease severities. And then finally, think about TYK2 inhibitors in clinic through a few cases that we have for you. Great. And with that, I'm super excited to share the podium with Dr. Lebwal, who is Dean for Clinical Therapeutics and Professor and Chair Emeritus at Icahn School of Medicine in New York. So please take it away.
Thanks, April. And I'm going to go through this really quickly, but I want to take you through a little history of, why do we have this drug, which I use a lot of, Deucravacitinib. And so this is the list of therapies that before Deucravacitinib existed for psoriasis. And so why did we have to add another drug to this list? And here's what happened. This drug, apremilast, comes out, and it's modestly effective, certainly less effective than most of our biologics. And in no time, in 2 years, the sales soar. This drug that is extremely safe, but not that effective. It's effective, but not that effective. And then the other thing that it's pointed out to you, that people who have, on these huge gene surveys that are done, they looked at different diseases that came up or went down, and people with mutations in TYK2 that render TYK2 ineffective don't get psoriasis. They have an 80% reduction in psoriasis. So what do you think the next logical step to do is? And of course, they did make a molecule that is very specific for TYK2. Very quickly, what is TYK2? It is part of the Janus kinase family. And there's JAK1, 2, 3, and TYK2. And what they do is they affect something called signal transduction. To make that complicated word very simple, phosphate is the message that triggers cells to develop what they're supposed to develop. So for example, Th17 cells make IL-17. What triggers them to do that? It's IL-23. There's a picture of that. There's IL-23 coming. It hits that receptor, cytokine receptor up there that's bound to the membrane, and then TYK2 mediates that message going through a molecule called STAT, which ends up activating the nucleus to make IL-17. And we know that IL-17 causes psoriasis. So very simply stated, if you can block TYK2, you can block this step. The patients don't make IL-17, their psoriasis goes away. And that's what happened. Now, TYK2 is very unique, and you probably all don't know this. When this molecule was designed, it won all kinds of awards because we have a lot of JAK inhibitors, and the JAK inhibitors all have an ATP binding site, and they all bind to that. And that's why when molecules come out and they say, well, this is JAK1 specific, it's a little JAK1 specific. It may affect JAK1 more than JAK2 and 3, but all of the JAK inhibitors hit that site. So they all cause a little inhibition of, TYK3 and TYK2. JAK2 and JAK3, and also of TYK2, which has that site as well. So they actually inhibit all of the Janus kinases. Now, TYK2 has a regulatory domain for which Deucravacitinib is specific, and it's the only one of the JAK inhibitors that hits that site. And that's why it can block TYK2 without affecting the other JAKs. Why is that important? So TYK2 is responsible for IL-12 and IL-23 and type 1 and Th1 interferons, interferon alpha and beta. And it's kind of like ustekinumab in a big way, which we know has a very good safety and efficacy profile for psoriasis. On the other hand, JAKs 1, 2, and 3 hit IL-2, which has many effects, and blocking that can be quite immunosuppressive. Erythropoietin, thrombopoietin, so it affects the bone marrow dramatically. Well, when you just block TYK2, it takes very little of deucravacitinib to inhibit interferon alpha, interferon beta, IL-12 and 23. It takes a ton of it to affect the other JAKs, IL-2 and the erythropoietin, thrombopoietin. So it is really specific for TYK2. It was a big campaign to get them to not put the boxed warnings that exist on the other JAKs on deucravacitinib because it is very different than the other JAKs. It is very specific for just this TYK2 cytokines, which are these cytokines. Okay, let me take you through the phase 2 and then the phase 3 data. So this was the phase 2 trial where they really knew they had a home run on their hands, and this was a dose-ranging study. So you see that there are many doses that were used. The 3 top doses ended up coming in one on top of the other. So 3 milligrams twice a day versus 6 milligrams twice a day versus 12 milligrams a day are almost at the same level in terms of PASI 75. They're those top three lines over here. When you look at PASI response rates, again, 3 milligrams twice a day, so 6 milligrams once a day is the drug we have, is pretty similar to 12 milligrams a day or 6 milligrams twice a day. So, not that different. If you look at PASI 90, again, they're one on top of the other. The results are virtually identical. And if you look at clear or almost clear, again, one on top of the other. In fact, 3 milligrams twice a day is exactly on top of 12 milligrams once a day. 6 milligrams twice a day was a tiny bit lower. And this is again at week 12. So you're seeing actually the 3 milligrams twice a day had a little bit better number than the 12 milligrams daily and a good deal better than 6 milligrams twice daily. So it was pretty logical from the dose ranging study that 6 milligrams once a day, or either 3 milligrams twice a day, but a once a day dosing has advantages. So 6 milligrams once a day was going to emerge. And you can see from the 6 milligrams twice a day and the 12 milligrams once a day that there was no advantage to twice daily dosing. So the once a day dosing appeared to be reasonable. Now there is some separation at PASI 100 where you see that 3 milligrams once a day is a little bit less than the 12 milligrams once a day. So, having said that, that holds out a little promise for other indications in the future where we might want to use a higher dose. Okay, and there's the PASI 100 data where you see that, again, 3 milligrams twice a day is a little bit less effective than the 2 higher doses. Okay, what about baseline demographics? This was a tough group of patients. A lot of them had been on biologics that either didn't work or certainly they just weren't staying on. And the other thing is they had substantial PASI scores, around 18 or 19, 17 to 19 actually, were the PASI scores in each of the groups. So tough group of patients. In terms of safety data, it was quite safe. No deaths, serious adverse events. There was one that was undoubtedly a coincidence, 2 actually, but undoubtedly a coincidence. It was, it was 1 and it was 2% of patients. The most common adverse events are what you would expect: colds, nasopharyngitis, and upper respiratory tract infections. Now, you might look at those numbers on top and say, well, that's pretty high. But when you look at the 12 milligrams once a day, it's not dose-related. So probably not a signal that the deucravacitinib contributed to those. Interestingly, acne at the highest dose emerged as a side effect. And how many of you have used deucravacitinib? Right, not many of you. It's surprising. I've actually seen acne. It's a small percentage of patients, and most of the patients I'm treating are older. So it's kind of unusual that you would see it, but I have actually seen acne as an uncommon side effect, but one that occurs. Here's the data from the phase 3 trial. And this is pretty eye-opening. So the top line is deucravacitinib 6 milligrams once a day. And you see that at the primary endpoint, week 16, it dramatically beats apremilast, 58.7 to 35.1%. Similar numbers in the other trial, a little bit closer though. And of course it beats placebo, which is the yellow line. I'll also point out that notice that the trajectory of the line is still going up. And in fact, if you look at 6 months, It's only starting to level off in the POETYK SO2 trial, still going up in the POETYK SO1 trial. And I actually tell patients this drug peaks at 6 months. So they've got to be a little more patient. I will say, if you look at week 4, the lines are beginning to separate. So there is some response at week 4, and we have seen that. Actually, I'll show you one of the first patients I treated after the approval of the drug. It's a 4-week photo. So you do see benefit as early as 4 weeks, but it's really 12, 16 weeks, and even 24 weeks where you see the peak benefits. So you have to be a little patient with it. If you look at the response at week 16, this is clear or almost clear. Again, similar curve, where you're seeing it's peaking at week 16, but goes up a little bit through week 24. And of course, it beats apremilast and placebo. Here again, you're looking at those responses. Let me just go similar numbers. Now, what about lasting through week 52? That study has been done, and you see that the line is just flat. So first of all, the placebo group were treated at week 16 and crossed over to active drug, and you see that they catch up very quickly to the group that had been on the drug from week 0. But notice that from week 16 to week 52, the numbers are almost identical. So the drug not only works, but continues to work. You do not get tachyphylaxis. You don't get the effect wearing off. This is a withdrawal and retreatment study. So what they do here is they take patients who responded, they put them on placebo, they wait for the psoriasis to come back, and then they retreat them, and they look at what proportion of patients recaptured the response, and it was 87.5%. So it's excellent recapture rate. Okay, when you continue on for 2 years, the line is flat. The patients continue to respond for 2 years. That was PASI 75 numbers. This is 1 year for clear or almost clear skin. Okay, this is a study just very quickly in Asian patients. The mean body weight tends to be lower, and so the results are actually a little bit better than you saw with the results I just showed. But everything else that I said is the same. It continues to peak beyond week 16 in some of the parameters measured, and the efficacy is, perfectly maintained through the 52 weeks of study. Okay, and when you look at the safety, again, the safety remains the same. And you'll hear more about that from April, so I'm going to turn it over to you, April.
Great, thanks, Mark. Excellent. So I am going to cover in my section 2 things. One is safety, and also some of the psoriatic arthritis data from the phase 2 studies. All right, so when we're thinking about oral medications, we oftentimes think about safety first. And I feel like for a very long time, we had to make a trade-off, right, between medications that work well in the oral realm, but then have significant safety issues, such as some of our traditional oral medications, versus something that's very safe, but potentially have modest efficacy. So let's take a look at safety profile of deucravacitinib. So here is looking at pooled safety of deucravacitinib comparing with apremilast and placebo. So let me orient you a little bit. Here is the placebo group. We have the deucravacitinib group and the apremilast group here. And the beauty of these trials, as Mark have said, is that you have an active comparator of apremilast. So what you saw was that pretty comparable rates of nasopharyngitis across during this placebo-controlled period. And here we have upper respiratory tract infections, also quite similarly comparable. What you see in terms of tolerability issues, so things like headache, diarrhea, and nausea, what you see is that the deucravacitinib group is at least the same or lower than that of placebo. So it's very well tolerated. And because we have the active comparator arm of apremilast, here, as we can see here, for example, headache rates are numerically twice as that of deucravacitinib, and then diarrhea and nausea rates are significant, are higher than that of both placebo as well as deucravacitinib. So not surprisingly, probably from these AEs that I've showed here, when we look at discontinuation rates, so these are patients who were enrolled in clinical trial, and then we want to see what percentage of them would discontinue by week 16. What we saw is that when you're looking at these three groups, deucravacitinib had the lowest discontinuation rate. And I think that probably speaks to the good tolerability of deucravacitinib in our patients. And then here, I also wanted to show you AEs where deucravacitinib is numerically greater than the placebo at rates 1% or higher. So as you can see here, there were low rates of upper respiratory tract infections, as we talked about, blood CPK that was transient, but typically the patients have continued the medication without and seeing the normalization later on. There are low rates of herpes simplex here that are pretty similar in what we typically see in the systemic trials. There were low rates of mouth ulcers, folliculitis, and acne, as Dr. Lebwohl have talked about earlier. But I think the magnitude of these is important to look at, pretty low. So we're looking at between 1.4% of acne. And so when we think about acne rates, for example, for JAK inhibitors that we have for atopic dermatitis, for example, some of them we're looking at rates of greater than 10%. So I think it's important to not only know what they may be, but also see the magnitude of those rates. Okay, and also there were AEs of interest that were studied, and overall what was shown is that there were no significantly increased rates of non-melanoma skin cancer in the deucravacitinib treated group as compared to the placebo or apremilast, nor malignancies, nor serious infections. Zoster was numerically greater in the deucravacitinib group compared to the placebo and the apremilast group. Your thromboembolic events were also similar to placebo as well as apremilast group, and also there were no increased rates of MACE events. Okay, what about laboratory parameters? So in the clinical trials, the patients underwent a number of different laboratory assessments and also at quite regular periods. So we have a very good understanding from our pivotal studies with regards to what happens to their labs over time. So here is week 0 to 16. And again, why the first 4 months is very helpful is because we have a placebo group. We also have an active comparator, apremilast group. And so what was shown here is that in terms of total cholesterol or creatine phosphokinase or neutrophils or platelets, overall, what you saw as a population level, they are very similar to one another. In fact, I oftentimes like to say if you remove these labels, you probably won't even know which group belongs to which when you look at these laboratory parameters. What was also looked at is hematologic parameters, right? These are important. Why? Because we want to avoid hitting JAK2, because the JAK2 combination is what's very important for a lot of our cell lines. So here we're looking at lymphocytes, neutrophils, platelets, and hemoglobin. And what was seen was that the laboratory parameters were within normal limits, and not only during the first 16 weeks, which I showed you earlier, but also extending to 52 weeks in patients that were treated with deucravacitinib. Some of the additional safety data I want to talk about is that we discuss very low rates, very well tolerated, very low rates of nausea and diarrhea, similar or even lower than that of placebo. And the low rates of zoster, it's about 0.9 per 100 patient years. And there are also low rates of follicular acne or folliculitis, 1.7 or lower. And then in the clinical trials, discontinuations due to the laboratory abnormalities in the deucravacitinib group was actually very similar compared to placebo or apremilast. In those with a liver disease, it's not a contraindication. However, if they do have liver disease, and if you're thinking about using deucravacitinib, you do then want to follow their liver function tests over time. A few other important clinical points to make is that, as you know, it's 6 milligrams once daily oral medication, so that's quite convenient for our patients. So it's for adults with moderate to severe plaque psoriasis. And I point this out because you don't have to fail in the package insert, you don't have to fail other therapies in order to get to deucravacitinib. So it's a moderate to severe adults with moderate to severe plaque psoriasis. And also, importantly, no tests are required prior to initiation other than TB. So you do need to check TB on everyone. If they have known or suspected liver disease, you probably want to check LFTs as well as viral serologies in them. And then there are no known drug-to-drug or drug-drug interactions to date. And then finally, for patients, they can take with or without food. Either way, they have good bioavailability of the medication in their body. Okay, so I talked about 16-week safety data. I talked about 1-year safety data. Now I'm going to take you through the 2-year safety data. Before we look at the 2-year safety data, it is important to know when the trial was performed. So in much of the 2-year long-term extension study, so the gray part is the COVID-19 pandemic. Okay, so as you can see, majority of the year 2 is actually spent during the pandemic time. So here, this side of the slide shows the different rates during 1 year, which we looked at. And then here are the 2 years. And overall, what we see is a very similar safety profile at 2 years compared to 1 year, with one exception is that you have COVID cases that are recorded, infections that are recorded during year 2. And as I talked about this before, to contextualize it, that during year 2 is when most of the long-term extension had happened. And in fact, when we were looking at this data, and there was a poster that was presented at the EADV that looked at whether deucravacitinib treated patients with whether their rates of infection were different from the general population. And then the answer to that is no. And then whether deucravacitinib treated patients, when they are infected with COVID, whether their outcome was different, and they compare that with the general population, they were also no different. So that poster, I think, was very helpful. And I know, Mark, I've seen you talk about that poster before as well. So I think that's quite informative, especially as we live with COVID from this point forward, is something to keep in mind. Excellent. So the next part I'm going to go over is whether deucravacitinib work in psoriatic arthritis. So let's take a look at the data. So I want to have you first focus on the left-hand side of this particular slide. And so here is the phase 2 data looking at ACR20 response, so at least 20% improvement in patients' signs and symptoms of PSA at week 16. And there were 2 doses that were used. So let me go over this. So the orange is the placebo rate, looking at proportion of patients who have achieved at least 20% improvement in their joint signs and symptoms. Then they have the 6 milligram group, as you can see here, in the middle. So that's about 53% of the patients achieve that. And then on the right-hand side, you have the 12 milligram QD group, so about 63%. So overall, what we see was that both 6 milligrams as well as 12 milligrams were statistically different from the placebo group. So as you can see here, I think when we're interpreting PSA data, we typically see for the systemic medications anywhere between 50 to 60 percent for ACR20 as a good response. So the phase 3 trials are currently ongoing. I also want to point out, in addition to plaque psoriasis and psoriatic arthritis, it's also being studied in inflammatory bowel disease as well as lupus. So I think this pathway is definitely being explored. And also, importantly, just speaks to the mechanism of action when we're looking at oral medications in development for our psoriasis. Most of it is focused on TYK2 inhibition, right? We don't see anything in late phase development that targets JAK1, 2, or 3 at all, actually, in psoriasis. So we're looking at people focusing their energy on TYK2. And also, in addition to that, when they focus their energy on TYK2, they're not blocking the active domain, right? We're getting smarter as a field, and that they're looking at allosteric inhibition, inhibiting the regulatory domain. Excellent. So I think overall, as we know, we do have many choices in terms of psoriasis treatment. So it does have to be a shared decision-making process. And I don't know how you feel about the shared decision-making process. I remember when I was in medical school, it's kind of like whatever the doctor said, the patient executed. But I think our field has evolved in a different way where we actually, by taking into patients' values into consideration, we actually can really help increase their adherence to our therapy. So I like this model where, as clinicians, our role is to convey some of the facts about the treatment, and we do want to make a recommendation, and then we want to solicit from our patients their values and preferences that we may not be aware of, and then working with them through that process. And I think ultimately that actually really improve the patient outcome, because if it's just one direction and unidirectional, maybe the patient is just not going to use the therapy. And so I think having the shared decision-making is important. So here, we're going to probably bring out a little bit later on through the case studies some of the discussion points. So for now, we'll just kind of think about could Deucravacitinib be used in those patients with potentially failure to topicals? How about the involvement of special sites? Those with a preference for oral therapy, and also whether they're oral therapy naive or experienced, could it be a possible candidate? How about biologic naive or experienced? All right, so this brings me to our case presentations. So there are two cases, and I'm gonna kind of start us off on one case, and I'll dialogue with Dr. Lebwal about this. And so this patient, you have to kind of exercise your imagination. It's a patient, then we imagine this patient having kind of different parallel universes that they live in. Okay, so imagine in one universe, this is a 35-year-old woman who's diagnosed with chronic plaque psoriasis for more than 15 years, a long time, 10% BSA, and also some nail psoriasis, right? Distal onycholysis of the fingernails. So, she has tried a variety of topicals, so very similar to the case that we just talked about, not satisfied, phototherapy, inconvenient. She's a little bit hesitant about injections, doesn't quite want injections. So here are some of the kind of options. And Mark, if you don't mind, sure. What kind of goes through your head at this point?
So I'm just going to focus on the nails for start. So first of all, the patient has limited disease. But when you have a treatment that's quite benign, as you heard the safety talk, there's no signal of anything bad. And the patient doesn't like injections, kind of directing you to an oral therapy. And of course, of the oral therapies that we have, this is certainly safer than methotrexate, and actually more effective. Obviously it wasn't a head-to-head trial, but the data here is better than what we see in the trials that are published for methotrexate, and certainly better, as you saw in the head-to-head with apremilast. So immediately it should come to mind. But what really I think of when palm or sole or nails are involved, biologics have difficulty getting to the tiny blood vessels that reach the tips of the fingers and toes. And so small molecules are actually often more effective. And so I would actually immediately, even if the patient did want and was okay with injections, and I love the biologics, they're very targeted, very safe, but I would start thinking about a small molecule here, and Deucravacitinib fits that description.
I think those are great points, Mark, especially about the size of the molecule and its penetration in our peripheral tissues. Yes. And I think also when we're thinking about overall treatment and the classification of psoriasis, is we're trying to kind of a little bit stay away from mild, moderate, and severe classification, but rather think about patients who are candidates for topical therapy versus those who are for systemic therapy. And for those, it's either, so the key thing is they meet either of any of those criteria, so BSA 10% or more, disease involving special areas, just like we talked about, nails, for example, and also palmar plantar area, scalp area, genital area, facial area, and then failure of topicals, regardless of location. We can think about our systemic medication, oral or biologics, in those situations. Okay. So now our 35-year-old woman, same presentation, now lives in the universe where she now is currently actually on a Premolast, but is considered a switch because she is experiencing some of the GI effects. And any thoughts on that, Mark? I'm making you work here.
Yeah, so this is easy because, there are no standout GI effects of Deucravacitinib, and it's more effective. So this is a no-brainer.
Yeah. Excellent. All right. Now, what if a patient has dactylitis on her second digit, for example, in the right hand? Maybe I can discuss that one. So as you can see in the phase 2 studies that Deucravacitinib was evaluated for the psoriatic arthritis signs and symptoms. So certainly something to monitor to make sure that the patient is not only responding from a skin perspective, but also from a joint perspective as well. Okay, and then imagine the same woman suddenly is now 67-year-old. So same woman, same presentation now in the third parallel universe. Somehow she rapidly aged to 67-year-old, and pretty much the same history. So this is having us think about, gosh, when we have patients, that are a little bit older and that are coming in, and is Deucravacitinib potentially a good option for our patients? What do you think about in this age group?
So I will say there's no safety signal in Deucravacitinib. It's a very safe drug. I mean, many of you would treat a patient like this with a TNF blocker in the old days when we didn't have anything, or a Premolast, which has a lot of GI side effects. And now we're looking at a drug with fewer side effects than those. So I wouldn't hesitate to use it.
Great. And I shall say that it was studied in the different age groups, and the efficacy of the medication and the safety of the medication
I will say,
was not different among the different age
You
groups.
mentioned herpes zoster, which the rate
Yes.
was 0.9 cases per 100 patient years. But you know that those 0.9 cases are going to be in older adults where the frequency of zoster is much higher. So, I have a very low threshold for writing a script for Shingrix for my patients, and specifically Shingrix, because there's no issue with live vaccines if you need to get them. Which Zostavax is, of course. And I would probably at baseline think about having the patient vaccinated with Shingrix.
That's a great point. Yes.
Start the TYK2, even though there's a series of 2, there'll be 3 months delay before you get the second.
I would start it. There's not great evidence with Deucravacitinib about vaccinations that I'm aware of. I don't know if you are. Certainly for the other JAK inhibitors, there have been some recommendations that you stop them for example, a week after vaccination. In fact, that's come up. The American College of Rheumatology with the COVID vaccine has recommended holding the JAK inhibitors. But we don't have any data on Deucravacitinib, and certainly ustekinumab has no impact on vaccinations. So here we're not just blocking what ustekinumab does, we're also blocking interferon alpha and interferon beta. But having said that, it's not a big deal to hold the drug for a week.
Yeah, exactly. That we don't have data in this area yet. So if you want to be safe, you can hold it for a few days, 5 to 7 days, and then after each Shingrix vaccination.
Okay, so I have a couple of teaching points with this case. So this is a 47-year-old man with psoriasis on his elbows, knees, and hands for 5 years, and it's severe, particularly on his hands. This is a real case. I'll show you before and after photos. Failed TNF blockers, failed ustekinumab, failed an IL-17 blocker, and he is currently on risankizumab with clearing of elbows, but no improvement on the hands. And that is a standard story. And if you look at any of the studies for palm and sole psoriasis, the drugs that work really quickly for psoriasis, they do work for palm and sole psoriasis, but you're looking at, instead of a 80% improvement by week 16, you're looking at maybe a 25%, and then 6 months later, a 50%. And it kind of hovers around there. They don't do nearly as well on the palms and soles as they do on the body. And there's several studies showing that. The Gesture study, which was secukinumab for palm and sole psoriasis, but there's several of them. We did a risankizumab trial, and the drug works. There's no question that it works, but it doesn't work as often as it works on the rest of the body. So here's our patient on risankizumab. And I'm going to show you the photos. This is a patient we treated. We added Deucravacitinib to risankizumab, and I'll address the issues of combination therapy as well. But there's the patient, and the drug's only recently on the market, so I don't have a long follow-up, but I'll show you he came back 4 weeks after starting. And there's the before, 24 days actually after starting. And there he is after just 24 days. So you see actually a fairly rapid improvement. And what it is, it's that it's a small molecule and it can get to the hands pretty quickly. So I know that the patient is still doing well, but I haven't seen him since that 24-day picture. And hopefully the next time you see me, I'll be able to give you a clear pair of hands at somewhere between 3 and 6 months. So again, that's 24 days after starting Deucravacitinib. Okay, so this is what it says on the other JAKs. Do not use in combination with biologic DMARDs. And the reason it says that is that when these were tested for other indications, for example, rheumatoid arthritis, they allowed the patients to be on methotrexate, which is much more dangerous than any of the biologics we use. But they never allowed them to be on biologics. And for that reason, it was excluded in the package insert. So it's not because of safety, it's not because of efficacy. It is because they weren't tested during the pivotal trials. Now, here's what it says on Deucravacitinib. Deucravacitinib is not recommended for use in combination with other potent immunosuppressants. So I have treated, at this point, several scores of patients, well, certainly close to 50 patients with Deucravacitinib since it was approved. And many of those, probably more than half, were combination therapy. Initially, we had 3 denials, and I simply wrote back, this biologic is not a potent immunosuppressant. We won all 3 cases right away. There was no pushback from the insurance companies. So we do have a large number of patients on the combination, and as expected, I wouldn't expect any side effects. I would not expect, I don't use a lot of TNF blockers. I use primarily IL-17 and IL-23 blockers, which are very benign. And the combination with Deucravacitinib means I'm taking 2 benign drugs, so we're not seeing any side effects. I mentioned I saw 1 case of acne, but not much else. So with that, let's open for Q&A.
Could you address usage in patients with history of malignancy? Any concerns at all in patients with history of malignancy? And also, you addressed the zoster thing. What about any concern about reactivation of hepatitis infection, hepatitis B? Do you test for that baseline? Do you recommend that? Or not necessary?
Yeah. So we both probably will answer this a little differently, but I'm curious what you would do. I know already what I do. Yeah.
Yes, so for malignancy, currently we don't have a lot of data from the clinical trials on malignancy, so I don't use it in patients with a history of internal malignancy or active malignancy. I don't have qualms using it in patients with a history of non-melanoma skin cancers in terms of malignancy. And with regards to viral hepatitis, it is the package insert does say that you do not use Deucravacitinib in patients with hepatitis B and C. So if you suspect that may be the case, I would advocate that you check those serologies.
Yeah, so my answer is virtually the same. So first of all, I compared this to ustekinumab, where we actually do have malignancy data, and there is no increase in malignancies with ustekinumab in the SOLAR study. However, this also blocks interferon alpha and beta, which is not blocked by ustekinumab. So I am also not comfortable yet using this. And we have very good drugs, IL-17 blockers and IL-23 blockers. More and more data is coming out, which appear to show them to be very safe. Certainly with the IL-17s, I think at this point we have large numbers of patients. A recent publication that I published was thousands of patient years of secukinumab-treated patients, and the rate of malignancy was 1% lower than the general public. So that's one group. So we have better drugs at this point. Without having the data here, I'm uncomfortable using it in malignancy. Although skin cancers like April, they're easily treated, they're minor, they're common, and I don't hesitate in a patient with a few skin cancers. As far as hepatitis B or C, so if somebody has hepatitis C, they should be cured. We have good treatments for that. That should be taken care of. If somebody has hepatitis B, if they're surface antigen positive, the risk of, they're already reactivated. And I send them to a hepatologist who, I can tell you what he'd say, although this hasn't happened yet. He would probably say, stay on the antivirals, you can continue on the drug. I have had it happen that a patient with core antibody positive came to me, and the hepatologist put the patient on entecavir, which is an antiviral. And the data, certainly with biologic therapies, is when patients are treated with entecavir, there's almost never reactivation of the core antibody patient positives. So the core antibody patients converting to chronic active hepatitis. So we do use, I send them all to a hepatologist, and he does follow their titers. We've not had one patient convert on any of the biologics when they're on entecavir.
Yeah, and I think for the clinical trials, as with almost all systemic clinical trials for psoriasis, the patients with positive hepatitis serologies are excluded. So that's why we don't have enough data in that particular area for deucravacitinib. Yeah. So I typically encourage my patients to stay on deucravacitinib. And the reason is because, when you look at the withdrawal data, they do experience a return of disease. I think around 3 months for them to lose their PASI 75 response on average. So I, in general, try to convince them to stay, especially if they're not clear. Then that's clearly they need to kind of stay on the medication. Where I consider possibly tapering is I also have patients on combination biologics with deucravacitinib. So I essentially treat them to clear with a combination, and then actually thinking about having deucravacitinib, then have the patient take them, for example, on the weekdays, and then going there to kind of dial down to a level where they will maintain their clearance, but perhaps not daily deucravacitinib. But this is obviously completely off-label, and we're kind of trying it out. So,
remember that the recapture rate's about 87%. So you're going to lose about 1 out of 7 or 8 patients if you stop the drug in terms of recapturing it. But I would have the same answer.
What about females of childbearing potential? Are you doing any sort of screening for them? Are we doing a TB evaluation? And then the second follow-up question would be, if you have a patient who does want to get pregnant and I start her on this, how much time should we say you take off before, okay, go ahead and start trying to conceive?
Yeah, so currently we don't have sufficient data, unfortunately, in females of childbearing age. Usually, I tell them that if they do think about family planning, to let me know. And I think for now, if they're actively conceiving, then I may consider a different option, because we have good biologic options, such as sertolizumab, which would, take them safely kind of through the pregnancy. So I probably would, wait until what the sort of the post-market, as we collect more safety data, have the pregnancy registry for it to be able to evaluate safety in pregnancy and breastfeeding.
Yeah, and we don't know that the drug is teratogenic at all. There's zero evidence of that. So if a patient was on it, hadn't planned a pregnancy, became pregnant, I wouldn't be that alarmed, but I would probably discontinue the drug for the same reasons that April said. The question was, is there a role for checking CPK? You want to?
Yeah, so I do not check CPK at baseline or follow them. In the clinical trials, there were a few patients with elevated CPK, which nearly all of them resolved with resumption of the medication. There were 2 cases of rhabdomyolysis that was noted in the clinical trials, one associated with a patient who was a female who started a very rigorous exercise regimen, and another one with a patient with multiple comorbidities who had essentially compartment syndrome in one of the arms. However, that's pretty rare, and I think so I know in the session earlier, general session, there was a discussion about CPK there as well. But in general, I do not check CPK at baseline or onward unless patient is symptomatic. But that's just my approach.
Yeah, the cases that had elevated CPKs, if they're looked at carefully, very often it followed, running in a marathon or over-exercise. And I don't think there's any reason to have to do it. And I did like what Linda Steingold said today about CPKs. Actually, we've had a patient on one of the hedgehog inhibitors, and those, of course, cause muscle cramps, and they are indeed associated with CPKs. And my patients went over 1,000. And, I was alarmed, and I called the nephrologist, who laughed at me. And, Linda said today that her nephrologist said, oh, you don't even need to be concerned till 5,000. Well, mine said you don't need to be concerned till 10,000. So we should probably have a bidding war there. But, but the point is you need many thousands to affect the kidneys.
What do you do for any baseline labs and or follow-up monitoring?
So, well, the package insert actually says very little. It says monitor lipids according to, I can't remember the wording, but basically what you would do in the general public. I can tell you what I do, and I think we gave you a handout today that listed what you need to do, and it's actually pretty easy for all the JAK inhibitors. You can take, except for Deucravacitinib, which requires much less. They all require baseline TB testing. We do check hepatitis. We check the same bloods we check in biologics. We check hepatitis profile. We check routine bloods, chem screen, CBC, because somebody ought to have that once every few years. We do check lipids. And for the other drugs, somewhere between 4 and 12 weeks, and if you go through the list of them, it was when they checked it in the trial is what you're told to do in the package insert. But the truth is, they pulled that number out of the air. So somewhere between 4 and 12 weeks, we would check a CBC and lipids, and we might check a chem screen as well for the liver function test. But that's it. And you do that once a year, except for tofacitinib, where you have to do it more often, according to the package insert. For Deucravacitinib, you almost have to do nothing. If you do, lipids according to routine, that's the routine for lipids is really for people with cardiovascular risk factors. If they don't have that, you check it every 5 years. So we have been checking lipids. It's a reason to bring the patient back and do it. But if you looked at the package insert, they don't call for much, right? Do I have
Yes,
that right?
yeah. So I oftentimes for lipids make sure that they have a primary care physician, and they probably know the lipid checking kind of frequency, because there's no additional above the general population recommendation that's placed on Deucravacitinib. So I'd say, do you have a PCP who kind of check you? You go to the PCP regularly. So that's I double check. But essentially, I check for TB at baseline, and then per package insert, if they do not have suspected or known liver disease, you don't have to check anything else. However, on the safety side, if you want to check viral serology, such as hepatitis B and C, I think that's a good precaution to do as we're getting more comfortable with the medication. But certainly, if they have known or suspected liver disease, it's not a contraindication to use Deucravacitinib, but just to follow their LFTs over time. And then for follow-up labs, there's no requirement in the package insert for Deucravacitinib.
Well, thank you, everybody. Thank you all for being here.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XMX860. This activity is supported through an educational grant from Bristol Myers Squibb.